Thank you for joining in the journey through the exciting world of hematopathology. As your tour guide, I will share and highlight several of the beautiful patterns that I have noticed and discovered, and also encourage you to discover some patterns for your own. This session is meant to be interactive, as shown by the presence of a workbook, which you have received on your table. And I call it a workbook instead of lecture notes to reflect that it should be an interactive session. So please be prepared to reflect upon and share some of your own experiences as we go through this journey. In terms of logistics, water and refreshments are in the back, the restrooms are around the corner. And if at any time you have any sort of questions or other concerns, just let me know and we can address them. And please feel free to follow me on X or Twitter at Hemepath is easy. All right, before we go into this, we have to deal with foundations. I like to take a foundational approach to hematopathology. Once you layer foundations, then you can build upon that and improve your knowledge over time and add to your framework. And the first foundations, as you approach topics such as hematopathology, are your beliefs and motivations. It's really important to have confidence in your ability to learn the topic of hematopathology. There's so many things, and sometimes it can be really easy to be overwhelmed and think that, oh, I'm not smart enough to get this. This is just for, those people. But no, there are patterns, there's order to all of this, and so you too can learn this as well. And just to try to make this point, turn to the next page, page 7 in your workbook. I want you to think of a time in which you had a light bulb moment within your medical career. Sometime that something really just made sense. You might have been struggling with something for a while, but then after a while you go back to it like, oh, all it was this, or something like really made sense. For me, one of those light bulb moments came actually right after I had to retake an exam. Once I realized why I needed to retake the exam, I understood the importance of the thing that I missed. And I missed a very big picture concept, which now I use every day. And that is the concept of differential diagnosis. And so the question was something to the effect of, someone presents with this particular symptom, what are 10 things it could be? And before not doing so well in that exam, my thinking was, if someone comes in with X, then the diagnosis is Y, and you're just kind of done. It might be 2 or 3 choices, but the idea of a wide, extensive differential diagnosis didn't really register with me yet. But after that exam, and having to go through the process of actually think of, oh, this could symbolize 10 different things, it helped me to realize the importance of the differential diagnosis and of being a little bit slower with your diagnosing to make sure that it is what you actually think it is and it's not other things. This is especially true in hematopathology, in which the morphology, in contrast to a lot of other specialties within pathology, in hematopathology, the morphology is part of the diagnostic process, but there is a very wide differential diagnosis just from the morphology alone. Give you a couple of moments to think. Even if it was something like, you know what, I like this specialty, or I don't like this specialty. Those are also very important light bulb moments to have. So yes, we have these aha moments. Sometimes when you're in the training, the information is just coming so quickly that you don't have time to really reflect upon and savor those moments. But especially before trying to deal with an extensive topic, it's good to remember those moments just to give yourself the confidence that you can go in with an open mind and believe in yourself. Because otherwise you'll put a roadblock to it and you won't even try. So it's important to have that belief that you are capable of learning this new thing, learning this topic. Second thing we want to think about, especially as adult learners, one of the concepts of andragogy, or the study of adult learning, is the different motivations for wanting to learn something. Adults have to have a reason for wanting to learn something. They have to know that it's relevant and applicable and useful, and it's relevant to their experience. So we also want to think about why you want to learn this. If you turn to the next page on the workbook, there's different sorts of reasons. And no reason is perfect. It doesn't matter which one it is, but it's just good to think about why you actually want to learn this. So one reason could be for curiosity. Hemepath is just interesting. And so that might be a reason to want to learn it. Another reason might be for the challenge. You say, oh, Hemepath is difficult, so I want to learn it just because other people say it's hard. And that's another reason. Another reason could be for competence. So as someone who would be in pathology or someone who's going to take a hematopathology position or hematopathology fellowship, you definitely want to learn it because it's your job. It's your responsibility to learn it. So that's another reason, which is a good reason. I put here celebrity because Hemepath is cool. I think that some other people may have different opinions, and it's okay that they're wrong. Or you might want to learn it because of cash or career, and you think that, hematopathology is reimbursed better than some other aspects of pathology, so that may be the reason you want to learn it. So I'll take a minute and think about what's your actual motivation for learning this. And then the next thing, after why you want to learn it, you want to think about when you actually use it. Again, that kind of leans into the motivation as to why you want to learn it, but specifically thinking about when you want to use it kind of ups the ante and tells your brain, this is really important because of X, Y, and Z. Now, this is also helpful for me because it helps me tailor the information to the audience. So will you use this in day-to-day practice, or is this necessary for standardized exams, for maintenance of certification? Or are you a medical student or a resident who just needs to learn this as part of your overall medical training, or is there some other reason which you're going to use this? So even for someone who's in family medicine practice, I will cover some of the, even though it's focused on the pathology of it, I will cover some of the clinical presentations. And this will also help you better understand the pathology report, especially the initial, if there's any sort of initial vagueness to the pathology report, this will help you make more sense out of it. So now we've talked about motivations. Now to start to set the basic foundation before we run through that. So what is the big picture? The big picture in hematopathology, I think, is the idea of hematopoiesis, the development of blood components. Now, what is in blood? We've got red blood cells, white blood cells, platelets, and then all the other fluid components that we're not concerned about in this particular lecture. Really, for hematopathology, we do deal with coagulation, with hematology, but this actually isn't going to deal with that because we're just dealing with the blood cancers. You don't have cancers of the liquid part. You have cancers of the cellular component. And so those cellular components have to come from somewhere. So where do they come from? They all initially start from a hematopoietic stem cell up at the top. In this figure, it calls it a multipotential hematopoietic stem cell. This really early stem cell can multiply, replenish itself, and it can also differentiate or become more specific, become more specified, get a more specific job. There are two main branches to this differentiation, myeloid and lymphoid. The myeloid side includes all the white blood cells, or the leukocytes, which eventually will turn to basophils, neutrophils, eosinophils, monocytes. Also, at this highest level of the common myeloid progenitor, if we call it, just for clarity's sake, a common big M myeloid progenitor, that also is the progenitor to the red blood cells. So in the broadest sense, red blood cells are of a myeloid-ish lineage. Now, this changes when we start to get to the actual evaluation of the bone marrow and that sort of stuff. We think of it as a separate erythroid lineage, but they both have the same earliest precursor. This is important to some of the chronic myeloid leukemias that we'll get to later, to understand that red cells and the white blood cells all have a common myeloid progenitor. This common myeloid progenitor also gives rise to megakaryocytes, which produce platelets. Megakaryocytes live in the bone marrow, and then they send out the platelets into the peripheral blood, and it's the platelets that you see in the peripheral blood. With some diseases, you can actually see a circulating megakaryocyte, and that's exciting for the hematologists and hematopathologists, but you're not usually supposed to see them there. So all of those are part of one main branch, the myeloid branch. The other branch is the lymphoid branch, and the common lymphoid progenitor can give rise to the different types of lymphocytes, B cells, T cells, and NK cells, or natural killer cells. B cells can then further differentiate into plasma cells. Some of them do, but some of them don't. And so it's not guaranteed that a B cell is going to eventually turn into a plasma cell. So there is, again, this big picture of differentiation, increased specification from the earliest precursor down to the most mature and differentiated blood cell components. And you'll see the platelets, white blood cells in the peripheral blood, and the lymphocytes. You'll see some of those in the peripheral blood, but you'll mostly see those in the lymph node. You also see them in the spleen and the thymus, but I'm going to focus on the lymph node for this particular presentation. All right. So when you have that basic framework of hematopoiesis, this is how things are supposed to develop normally. And when you have abnormalities, then it gives rise to an abundance of blood cell cancers. Now, in order to think that you might have a blood cell cancer, you have to find something that's abnormal in that process. And so what are our main ways of looking for something that's abnormal within that process? We can look for three things. So an abnormal phenotype. So as you go through that process, there are certain proteins that are expressed on the cell surface, and it's supposed to happen in a particular pattern. So if you see things that are not following that pattern, either proteins that are there that are not supposed to be there, or loss of proteins that should normally be there, then that's an abnormal phenotype. And there are different ways of testing for that information. The tests are flow cytometry and IHC, or immunohistochemistry. Sometimes you can see an abnormal phenotype or difference in maturation just because the cells look weird, and so decrease in maturation. So sometimes they just using the microscope can help you see that it's not acting correctly. The other main branch is clonality. So if the same thing is cloned too many times, that's another marker of abnormality within the hemepath world. And there's different ways of studying that. You can look at immunoglobulin heavy chain studies by PCR. You can look at T cells, PCR. Other ways are looking at the way that the chromosomes are rearranged, so with cytogenetics or FISH, or looking at particular gene mutations, so specific A to G mutations or whatever in the DNA through next generation sequencing. A final big marker for abnormal is the one that's actually probably most relevant to you, which is doing bad things. So when the patient comes in and they say they've had night sweats, chills, and there's this big 10 centimeter mass in their neck, that's doing a bad thing. They're having symptoms. You can see that from the physical exam or CT or ultrasound and that sort of thing. Masses in the retroperitoneum, you might see something there. You get the CBC back and the white blood cell count is 300,000. That's not good. Or by the same effect, the white blood cell count is 0.3. Or, we look at the platelets and the platelets are like 1 million, or they're less than 20. So all of these, and then, by the same token, even if the red cell mass is increased. So if you have a hematocrit, say 17, 18, 19, then that's going to be a problem. Or by, on the other side, if you have a hematocrit of 6, you're going to be concerned. So you need all three of these components to be able to specifically diagnose something in the hemepath world. Since there's so many ways that things can go wrong, so many ways that you can have an abnormal phenotype, different mutations, so many ways that they can do bad things, there's lots of names. And so what do some of the names mean? The big picture names that we have are leukemia and lymphomas. We'll go over leukemias first, and then lymphomas. Leukemia is a blood cancer, blood cell disorder that typically occurs in the peripheral blood or in the bone marrow. And so sometimes you will see part of the manifestation of the disease in the peripheral blood, but you'll see the full manifestation in the bone marrow. Sometimes you'll see enough of the manifestation in the peripheral blood that you can kind of know what it is, but you'll still want to look at the bone marrow to see if it's progressed to something worse. But leukemias are found in the peripheral blood and the bone marrow. And that's why when you see several of these abnormal signs and the abnormal features in the peripheral blood, it will lead to a bone marrow biopsy with flow cytometry, cytogenetics, molecular for the final diagnosis. Because many of these, the bone marrow is where you're going to do the final, official gold standard counts, right? So leukemia, location, peripheral blood, or bone marrow. As we mentioned before, with the big picture hematopoiesis, there are two main branches, myeloid and lymphoid. And so you can have leukemias of either branch. You can have leukemia of, I'll start with the lymphoid branch, and those can be further broken down into what I'll call acute lymphoid leukemia, which actually goes by the name acute lymphoblastic leukemia, and those can be of B cells or of T cells. And so the abbreviation, which everyone from medical school I think knows, is ALL. And so you can have B ALLs, B cell ALLs, or T cell ALLs. And those are going to be acute lymphoid leukemias. So once you have a increased white cell count in the peripheral blood, and you're thinking it might be leukemia, you break it down into which branch it goes down, to which main branch, whether it's lymphoid or myeloid, and you can think of whether it's acute or chronic process. And it gets a lot closer to the name by going down this pathway. Now, for the acute side, it's a little bit easier. For the chronic part of the lymphoid, it's a little bit more complex because there's more names to the chronic type lymphoid leukemias. But you can still get to a big bucket, and we'll go through some of the differential diagnoses with the chronic leukemias. So, in the chronic B cell leukemias, such as CLL. So in the name, it has chronic lymphocytic leukemia, but there are other chronic type B cell leukemias. There are T chronic leukemias, lymphoid leukemias, and there's AK chronic lymphoid leukemias. Sometimes they're called chronic lymphoproliferative disorder. Lymphoproliferative disorder is Just another descriptive big name category for lymphoid cancer. Right. So that's the lymphoid side. You can also break it down on the myeloid side, and they can have, again, acute or chronic processes. And just like on the lymphoid side, the acute processes are pretty straightforward. And the myeloid side, the acute processes are straightforward as well. And if it's an acute process with increased blasts or increase of precursor cells, myeloblasts, that's going to be an acute myeloid leukemia. Now, there's lots of different types of those, but at least once you get in that room, then you can figure out, things with more specificity. And also from the clinical perspective, you're going to see something diagnosed as acute myeloid leukemia first before the additional tests are done to figure out what specific type it is. Then for the chronic myeloid leukemias, I think of these as leukemias that you don't necessarily have to treat today, maybe next week or beyond, whereas the acute myeloid leukemias you want to treat today. The same thing goes for the lymphoid side. The acute ones are the ones you're going to treat today or tomorrow at latest, and the chronic ones are ones you can maybe treat next week or some other time. You got a little bit of time to look it out. As I mentioned before, on the chronic side, things are a little bit more complicated. There is the specific chronic myeloid leukemia, which is a specific diagnosis, but there are other chronic type myeloid leukemias, and these are further broken down into myeloproliferative neoplasms, myelodysplastic syndromes, myelodysplastic neoplasms, which go by the acronym MDS, and this myelodysplastic myeloproliferative neoplasm, which is an overlap, and it's abbreviated MDS/MPN, where the slash is not an either or I don't know which one it is, it's actually both and. So it has features of MPN and features of MDS. So these are the big name categories. And again, you can use, I like to think of it as navigating through the diagnosis. Once you have an abnormal finding on the peripheral blood, then you can ask yourself the question, is it myeloid or lymphoid? Is this an acute or chronic process? For lymphoid, is it B cell or T cell? And you can navigate through the diagnosis step by step. And you can deal with everything if you go through this process. Then there are lymphomas, in contrast to leukemias. So leukemias are located in the peripheral blood or in the bone marrow, whereas lymphomas are located in a lymph node or mass. Lymphomas are not myeloid, they're only lymphoid. And this is good because the name has lymph in it. So lymphomas are going to be lymphoid. And just as we broke down the lymphoid leukemias, we can break down the lymphomas into B cells, T cells, or NK cells. We can also put plasma cells in that box as well, because plasma cells are further specified B cells. But we can think of plasma cells in this category as well. But then you get to names that are slightly different, such as myeloma. But we can still put it in the big box of lymphoid differentiation. When we think of B-cell lymphomas, we can further break these down into differentials that have predominantly large cells or predominantly small cells. And so whether you have large cells or small cells, it's partly a morphologic thing. You look at the microscope and make a determination. Lymphomas with small cells will have lymphocytes that are 1 to 2 times the size of a normal small condensed lymphocyte, whereas large cell lymphomas will have lymphocytes that are 2 to 3 times the size of a normal lymphocyte. So it's not super complicated, it's just you have to understand what is large and what is small. Any differential that you have based on these is going to be very different. So that is our basic framework. We dealt with our beliefs and motivations, and then the big picture of hematopoiesis, how to define or how to identify abnormalities, and then a preview on what the names mean. And with this foundation, then we can go to the application and figure out how to identify these things easily, or have pros to identify them. So now how to apply these concepts to build upon our foundation of hematopoiesis, looking for abnormalities and naming things in order to come up with specific diagnoses. The question is, how do you actually learn this? How do we approach the big topic such as this? Let's do a mind example. So let's pretend you are a teacher. You walk into a classroom and you see a person there. Name is Robin. Now, in this case, Robin is blue. Can't tell whether Robin is tall or short, but I think it's tall. And what are the different things we can know about such a person, Robin? Well, we can know that they love to play baseball. We can know that they live in Philadelphia. We can know that they're a plumber, or they want to be a plumber when they grow up. We can know that they're the first of 10 kids, and that one of their parents is an engineer. Those are all the things we can know about Robin. Then you meet someone else, Corey. Now, Corey is short, and Corey wants to be an astronaut. Grew up, loves Italian food, loves soccer and foosball, and the parent is a high school principal. Go down the list. Billy. Oh, Billy is wearing glasses. Billy is tall. Billy has a yellow clothes on. They love peppermints. They love tennis. They want to go snowboarding and skiing every summer. So we can go one by one through people like this. And this is often the way that pathology is presented. And if we do that, it's a lot of information, right? It's like, okay, I can go through this, and if I go through 10 different people and talk about all these characteristics and features, at the end of it, if someone random comes up, are you going to know who that person is? No. So if at the end of this, I say, who is this? You're just going to be like, okay, I give up. I don't know. Next question, please. So I think when you have this approach towards pathology, it makes it a lot harder. Yeah, you don't know who you're missing. You don't know how many there were. You have no framework for it at all. So instead of that approach, let's say you're a teacher, and before you go into the classroom, you have the class roster in front of you. And so you say, okay, there are 10 students. There's a lot of them with A, B, 4 C's, 2 J's, and 2 R's. And then you go into the classroom, and everyone's all jumbled, but there's 10. And then you ask them to reorganize themselves according to some basic characteristics. If you do this, group all the tall people together, group all the ones who are wearing yellow, group all the ones with hats together, and you can identify the defining characteristics. And then once you have those, as you talk to the person over time, you'll learn more about them. You'll learn their likes, their dislikes, what they want to be when they grow up. But you know who you're talking to. Before you go into all the nitty-gritty details, it's important that you just have the basic differentiating features first. This is what we do with people. I think it makes Hemepath easier when we do it with hematopathology. If we just look at the list and then look for the defining features. Now, at first, it might seem a little bit intimidating because the list can be long. But if we further break it down into these defining characteristics and think about how we can distinguish them, it becomes a lot easier. And if we compare this to the one-by-one approach, it becomes a million times easier. And you're not concerned about who you're missing because you know the class roster and you know the defining features. So we're going to take this approach towards our blood cancers. And the first one we're going to do it with is acute myeloid leukemia, or the acute myeloid leukemias, because there are a lot of different types. This is what they generally look like. There are specific details that you can find in other ones, but they are not necessarily diagnostic features. They're features that will help you lean towards one way or the other, but you're ultimately going to rely on the final pathology report once you've gotten all the actual diagnostic tests. And so you'll actually find pictures and that sort of thing on standardized exams, and they'll want you to give a spot diagnosis, but this is not how you practice. It's not how you practice. You see things that make you concerned for something, you do the gold standard diagnostic test to make sure it is that thing, and then you can treat that thing. Because there's lots of what we call morphological overlap. Something that looks like this could be any of 36 of the different acute myeloid leukemias. So it's important to get all the information before you actually make the diagnosis. So there are 38, and I'll call it 38 flavors of them, of acute myeloid leukemias. We have those with defining genetic features. We have those that are associated with eosinophilia, so increased myeloid blasts and increased eosinophils. We have those that are mixed phenotype, so they're a little bit weird. They have some features of myeloid differentiation and some features of lymphoid differentiation. It's a dual thing. There are others that are defined by the morphology, so what they look like, if you have ruled out the specific genetic features. There is one that is tissue-based. They don't call it a lymphoma, though. Call it a sarcoma, or whatever the reason is. That's kind of doesn't make sense, but I guess it can be. I'm not sure why they use the word sarcoma instead of something else, but it is a acute myeloid leukemia flavor. There are others that are secondary. It becomes an acute myeloid leukemia picture after having some other disease or other genetic predisposition. And then the one that is post-chronic, post-myeloproliferative neoplasm, which is also, it's actually a type of secondary, but it's a specific type of secondary. So this is breaking it down into 8 categories, but then we can even summarize it even further into 3 categories to make life even easier. The genetic ones, the ones that are defined on morphology or immunophenotype, and the ones that are defined by history. And so we have 38 flavors, but we ask these 3 questions, and it makes life infinitely easier. So we'll start off with genetically defined ones. And to deal with these from a clinical perspective, either as someone who's actually seeing the patient, primary care, or hematology oncologist, or even from the pathology perspective, you will see something that looks like this on the slide, and then you will send off, hopefully you'll make sure that the cytogenetics and FISH studies have been sent off, which will look at the physical nature of the chromosomes. And then you wait for cytogenetics and FISH to do their thing, and you will look at the report, and if any of these things come up, then there's your diagnosis. Now, it's not really good for test taking, maybe for step 3, because they actually have it that you can look up reports, like order something, and they might give you a report back, and then you have to interpret that. But for step 1, they don't do that. Step 2, they don't do that. But for maybe step 3 and for actual practice, you don't have to memorize all this. Keep the list. You consult the main list, the World Health Organization list of hematopoietic neoplasms, and you check the list. So there's the PML RARA fusion that you can find, which is a 15-17 translocation that you see in acute promyelocytic leukemia. And then all the rest of them, in acute APL, that's why I have that here, that's still a type of acute myeloid leukemia. And then all the other ones, the name will be acute myeloid leukemia with fill-in-the-blank fusion. So acute myeloid leukemia with RUNX1 T1 fusion, acute myeloid leukemia with CFB, MyH11 fusion, acute myeloid leukemia with DEC NUP214 fusion, and so forth. Acute myeloid leukemia with KMT2A rearrangement, acute myeloid leukemia with MECOM rearrangement. These ones that have fusion or rearrangement will be on your cytogenetics report, and the ones that say mutation will be on the next generation sequencing report. So NPM1 mutation, you can't find that by cytogenetics, you find that with next generation sequencing. CBPA mutation, you can find that with next generation sequencing. This last one, myelodysplasia related, you'll find that on next generation sequencing as well. For this one, you'll still have greater than 20% blasts like you see like you need for all of your acute myeloid leukemias. But then it's called myelodysplasia related. You often see dysplasia or lack of normal maturation in the granulocytes. But this myelodysplasia related means that there's an actual separate list of mutations that you'll see. So things such as ASXL1, TET2, B-core, it's a list of genes. But basically, if there's no rearrangements and they don't have these fusions, the next generation sequencing report will tell you whether there's one of these myelodysplasia related mutations, and so they make that diagnosis. The main categorization also has this extra category, other defined genetic alterations. They have that to acknowledge the fact that there are some things that just haven't been studied very well, and so they're leaving room that there are some things that are out there that we just don't know about yet. So if you find these fusions, you're pretty much done. Same thing happens for these myeloid lymphoid neoplasms with eosinophils. And so you'll see blasts in the peripheral blood. You'll also see eosinophilia. And so you'll say, we want to make sure we do an eosinophilia cytogenetics FISH panel. And they will test for all of these for you. And so you see if it's on the report. They have such specific names because these are typically all mutually exclusive. So you'll have one of these and not the other ones. If for some reason you have some like myelodysplasia related mutations and one of these eosinophilia related rearrangements, then this category takes preference. So if there's more than one, this category wins. There's not going to be more than one of these. You might have an extra one of these with some of these. If that's the case, these take preference. These take preference. These are the ones that are defining. And so the way you do it is you test for the most complex ones, and then if you rule those out, then you're left with more and more non-specific diagnoses. So for all these, and then for the mixed phenotype, again, you're going to, in the peripheral blood, see blasts that are myeloid and some blasts that are lymphoid, and so you'll think of a mixed phenotype, but again, you'll still send for the cytogenetics report, cytogenetics and FISH, and if you see such as a BCR-ABL1 fusion or KMT2A rearrangements, then it's going to be mixed phenotype. Mixed phenotype acute leukemia. And then they also, for all these classifications, they leave room for if we discover more in the future. In reality, it's 20 real ones and 3 placeholders. So this is how we get to the first 20. You see this in the peripheral blood, send off for your cytogenetics, FISH, and next generation sequencing. And the diagnosis is going to be whichever one they find. So this is how we practically do it. Now this, like I said, for step 1, it's not necessarily the greatest. For step 2, not necessarily the greatest. Step 3, could be useful. But I think it is useful, even for test taking, just to have this framework in your mind, because as you read the question, as you either read the question stem or deal with the patient, you have these big picture questions. And you know that those are the places where you're going to be looking to finally actually get your answer. And in real life, we have the textbooks, we have the lists. And if this were a cytogenetics lecture, then they would have to learn how to identify these things. But that's just a morphology. They have to recognize chromosome 15, recognize chromosome 17, and know when the banding pattern looks weird. So this is the first 23, genetically defined. Now this takes priority. If You send off for those tests and everything is clear, which is going to happen in like 0.1% of cases. So this should take care of greater than 95% of things. If for some reason there's nothing that in the cytogenetics report, there's just normal karyotype, no NGS mutations, no molecular mutations, then we can go down the second list of defining acute myeloid leukemia by morphology or immunophenotype. And again, as we talked, under the big picture of hematopoiesis, when we think about how maturation goes from an earliest precursor to the more specific granulocytes and to monocytes, if your acute myeloid leukemia there's no differentiation or minimal differentiation, then that will be the name. If there's all immature precursor proteins, if there's a few proteins, but it's not very specific, then you can go to acute myeloid leukemia without maturation. That's just kind of barely going down the maturation. If it's going a little bit further, then you can call it acute myeloid leukemia with maturation. The maturation is relative. They're not maturing to mature neutrophils. This is just, they look like blasts still, but they might have, a weak myeloid marker such as CD13 or CD33 versus not having anything specific. There's acute basophilic leukemia, in which you would, see some basophilic type of maturation. Acute myelomonocytic leukemia, where you start to see them develop into myelocytes and some monocytes. So for acute myeloid leukemia, you need greater than 20% blasts, usually, unless you have these defined genetic mutations. But that means you can still have 70% of other cells. And so in the 70 to 80% other cells, if you're seeing lots of myelocytes, lots of monocytes, or things that looks like erythroids, then you can consider some of these other types of acute myeloid leukemias based off of maturation. And these are going to be based off of just kind of what you see under the microscope. Same kind of general process goes for the mixed phenotype. Again, if you see acute myeloid leukemia and B-cell differentiation, then you'll describe it as mixed phenotype acute leukemia B and myeloid, versus if you see myeloid differentiation and T-cell differentiation, then it's T myeloid. Again, these are diagnoses. You can think of them as diagnoses of exclusion. If you've gone through the other list and found nothing, then you can default to these. The other one, as I mentioned before, myeloid sarcoma. This is a manifestation of acute myeloid leukemia. Many of these actually can fit into some of the genetically defined ones, but it's a different type of presentation. It's myeloid blasts that instead of presenting in the peripheral blood or in the bone marrow, it presents as a mass somewhere. And so sometimes I've seen it as a GI mass, and it turns out to be myeloid sarcoma. Sometimes it's in the patient, or it can be in the liver. Sometimes it's in a patient who already has a history of acute myeloid leukemia, and so it just spreads that spot, and the cells collected there. But sometimes you can find the myeloid sarcoma first, and if you find the myeloid sarcoma but without a systemic leukemia, if it has one of these fusions, it's still going to be considered a acute myeloid leukemia equivalent and be treated as such. But these are uncommon. Like I said, I remember seeing one in the GI. I've seen a few of them. And if we count through all these, there's 11. Then the last category, big group, is based on history. There's 3 different types of history we can find here. Genetic history. There's myeloid neoplasms that are associated with a germline predisposition. So if you have a T53 germline mutation, have Lymph syndrome, where you get lots of other cancers as well. The hematopoietic system is not necessarily spared, and so you can have an acute myeloid leukemia as well. And if you have that, then you would consider it because of the germline predisposition. There are some that are associated with Down syndrome, and again, this is a separate type of category. And then there's a treatment-related myeloid neoplasm, which is a sad condition in which someone gets some other cancer, say breast cancer, colon cancer, or whatever. They get treated for that cancer, but then the drug that was used to treat that cancer causes acute myeloid leukemia or a myelodysplastic syndrome. So they're cured for one, but then this other one shows up. Usually there's 2 main buckets, either 1 to 2 years later or 5 to 10 years later. But again, we'll find that out by checking the history. And so we find that the person has been treated for breast cancer, then they get into that category. Then the final one, post-myeloproliferative neoplasm blast phase. So myeloproliferative neoplasms are a chronic type of myeloid leukemia. However, if they sit there for a long time and are untreated, many of them can actually progress to an acute myeloid leukemia, a blast phase. So that's actually why we want to treat them early, to see if we can slow down that process of converting over So this can happen for all of them, even for the prototypic chronic myeloid leukemia that's defined by the Philadelphia chromosome. That one can convert to a blast phase. Now it shouldn't now because we have really good treatments for it, but it still can rarely. All right, so even though there's 38 altogether, we have our big buckets, and we can deal with all of them with 3 steps. Find the cytogenetics report, cytogenetics, FISH, and NGS reports. Describe what you see if there's any sort of differentiation that you can tease out, and check the history. Now, if you have all these points, then you can go to your charts and identify them. Pretty straightforward. It becomes difficult if you don't have all this information. And so it's really important to just get the information before you try to make a super specific decision or super specific diagnosis. This is how you get through 38. 38 boiled down to 3 steps, all right? So this is how we do it. And if you've gone through these steps, you don't have to be scared that you're missing anything because you've covered them all. At the very beginning, you've gone through, like I said, it's a little bit intimidating at first to look at the number, but if you have taken them all into account on the front end, then you know that you're not missing anything when you get to the end of your process. I think we can go through this next one pretty quickly as well because it's similar to the one before. B acute lymphoblastic leukemias, there's 13. Oh, forgot to mention, I'm not going through everything. I'm focused on, if you look at the table of contents, I have myeloid, acute myeloid, chronic myeloid, and then B-cell things. Acute and B lymphoblastic leukemia, and then B-cell lymphomas. I'm actually not covering B-cell leukemias, I'm not covering T-cell leukemias or T-cell lymphomas with this today. However, with this approach, it should empower you to be able to go and try to find the diagnostic categories and find some of the key differences and make more sense out of it. So for B acute lymphoblastic leukemias, there's 13. And this one's actually more straightforward than the acute myeloid leukemias because, again, most of them are genetically defined. So if you look at all of these, B lymphoblastic leukemia with high hyperdiploidy, with hypodiploidy, with amplification of chromosome 21, BCR-ABL1 fusion, CAMT2A rearrangement, ETV6 RUNX1 fusion, TCF3 PBX1 fusion, IGH-IL3 fusion, TCF3 HLF fusion, other defined genetic alterations. All of those are going to be based off of your cytogenetics report. So that covers 10 of them. The 3 that we missed are NOS, which means we've gone through all this and found nothing, and these ones with the ones that say like features, BCR-ABL1 like features, ETV6 RUNX1 like features. I have them in this list here because it's by the fusion, and I think that might be a little bit easier to see than if they were separate. But for those 2, those are going to be defined by gene expression profiling. So it's another type of test. They have immunophenotypes that are similar to the ones like you see in BCR-ABL1 fusion, ETV6 RUNX1 fusion. But again, the phenotypes have some variability to them. The gold standard diagnostic tool is finding these rearrangements. So all the phenotypes are bonuses. Those might just have you think that something is likely, but these are the defining things. This is how we would practice. For test taking, they assume that there's a 1-to-1 correlation, but life is not like that. And even if you read the diagnostic criteria, the diagnostic criteria are in the World Health Organization, that's the 5th edition of Catalog of Tumors of Hematopoietic Neoplasm. So even the way that they're written there, they will use terms like usually, often, there's essential criteria, desirable criteria. So those are not gold standard. The rearrangements are the gold standards. So ultimately, for practice, that's what you want to hang your hat on. And all of the other details are bonuses once you already have the foundation of, you enter a room full of people, there's only one person with a hat, his name is Jimmy. Now you can learn more about Jimmy after you know he has a hat. So these are the defining features. Everything else is bonus. So practically, you would wait for the reports, and if there's one of these, you'll find them. And if there's not one of these, then you'll consider whether you'll do gene expression profiling if you're at a research center for the BCR-ABL1-like features as an expression profile like the BCR-ABL1, but doesn't actually have the BCR-ABL1. The same thing for the ETV6 RUNX1-like features, has some phenotype like ETV6 RUNX1 fusion, but doesn't actually have that fusion. And then if none of those match, then you're going to be left with NOS, not otherwise specified. And again, as clinicians, you have the list. So this is more about trying to navigate through the diagnoses, having a process, knowing the options that are out there, knowing that you have choices, and being able to describe, like in general, the types of choices that you have. Once you have that foundation, then you build upon that over time as you become more and more familiar with the entities. So 2 steps, as I mentioned before, send for cytogenetics, Find the FISH report. That takes care of 10. If that's negative, then send for the gene expression profile, potentially. Again, that's probably something that you'll do more of in an academic center. If you're in the community, then diagnosis from your community pathologist is probably going to be acute lymphoblastic leukemia. They might call you to see whether you're going to send them, whether the person's going to go to a big name academic place where they'll do more of the fancy things to specify it more, give more specificity. All right, next one, chronic myeloid neoplasms. Briefly alluded to this earlier, that there are different categories. There is the standard, specific chronic myeloid leukemia with the Philadelphia chromosome that you've learned about in medical schools at some point or another. But there are other ones, other chronic type myeloid neoplasms that are stem cell disorders of myeloid lineage, and they have a chronic time course. These can be further broken down. So when we say myeloid neoplasms, this is a big picture term. It's often used when we don't know which one of these it actually fits into, whether it's myeloproliferative, myelodysplastic, overlap, or an acute myeloid leukemia. This can be the case when we might see some blasts, but it's not enough to reach the acute myeloid leukemia threshold, or if we just don't have enough information yet. But it's kind of like a placeholder. It just says we've made it this far. We have to do more digging, more studies to get more information about this before we further specify it. We're going to start off with the myeloproliferative neoplasms. With this, you want to ask yourself the question, what's up? So with the myeloproliferative neoplasms, there's always going to be something in the CBC that is elevated, either platelets, white blood cell count, or hemoglobin hematocrit. What's up? For MDS, you're going to be thinking what's down. There's going to be some sort of cytopenia. There might be more than one. Either leukopenia, anemia, or thrombocytopenia. For the MDS MPN, it's both. What's up and what's down. You need one of each. And as we covered before, acute myeloid leukemia, you need more than 20% blasts or one of the other defining rearrangements. So as we mentioned before, with the myeloproliferative neoplasms, you ask yourself the question, what's up? And you have three choices: white cells, hemoglobin, and platelets. And we can draw a lovely Venn diagram of all the possibilities. You can either have white blood cells by itself, or you can have the white blood cells and hemoglobin, white blood cells and platelets. You can have hemoglobin and platelets, or you can have all three that are up. So 7 distinct areas. Even though there are 7 adult choices, each of these quadrants doesn't actually apply to a choice. So basically, if you have increased white cell count, if it is of neutrophils and has a specific molecular marker, then it's chronic neutrophilic leukemia. If it is of eosinophils and you have a clonal marker, harder to pin it down for that one, but if there is one, then it would be chronic eosinophilic leukemia. So usually for the CNL and the CEL, the counts of that particular lineage will be really elevated, 20, 30. But if it's a little bit less elevated, something like the 15 range and chronic, then other things that you can think of are PMF, primary myelofibrosis. This gets a little bit tricky, and we'll go into a little bit more detail as to when you should really think about primary myelofibrosis. But that would also be in this part of the Venn diagram. If there's increased hemoglobin, then that by itself is enough to make you think about polycythemia vera. So that's our PV. And unless you have like a ton of neutrophils and a ton of eosinophils for CNL and CEL, then if you have increased hemoglobin, then you're most likely going to be fulfilling criteria for PV first. The other thing we have here is if you have isolated increased platelets, then you can think of essential thrombocythemia, or essential thrombocytosis, ET for short. Now, these are within those smaller circles of the Venn diagram. And notice there's a larger circle here. And within this larger circle, we have CML, which is our prototypic chronic myeloid leukemia, and MPNU, which is myeloproliferative neoplasm unspecified or not otherwise specified. This is to show that CML can present like any of these. So the first step for anything that's any cytosis is, of course, after all the like reactive things and high altitude and smoking, all the other sort of stuff, if you think it's a neoplasm, you have to rule out CML. So you rule that out first, then you can go to these other sorts of things. And if there is a cytosis, but it doesn't quite meet the documented thresholds, or when you do a bone marrow biopsy, everything is just so fibrotic that you can't tell what's coming and what's going, then you're left with this MPNU, which basically says there are some cytoses, and it seems like a myeloproliferative, but we can't specifically categorize it. If we think of these myeloproliferative neoplasms as occurring over time, there's a time in which you didn't have it, there's a time in which you start to develop precursor symptoms, and you start to see more of the diagnostic features. And then if you don't do anything, then your marrow will fibrose completely and it can switch to acute myeloid leukemia. I think of the MPNU as if it's like too early to get the diagnostic process or to have the diagnostic features, or if it's so late that everything is fibrotic. Then you're left with this, it was or is going to be MPN, but I think our timing is off. Now, when you have an MPN, myeloproliferative neoplasm, again, your first step to thinking about these things is you see something that's elevated in the CBC. You'll want to do a bone marrow biopsy. The bone marrow biopsy should have these types of features. So usually for CML, you're going to have increased megakaryocytes, increased everything, basically. But the defining thing is going to be this 922 translocation. For PV, ET, and primary myelofibrosis, they will often have a JAK2 mutation, which you would see from NGS on your next generation sequencing report. ET and PMF can have MPL or CALR mutations as well. But again, all these are things that you would find on your next generation sequencing report. So clinically, you'd probably have one of these things elevated in the peripheral blood. You'd send for peripheral blood, maybe JAK2 testing. You'll find that it's positive. And then you have to do a bone marrow biopsy to see which morphology fits best. And the pathologist will help you figure out which one of those it is. For these other two, CNL and CEL, I mean, the diagnosis is kind of in the name, neutrophilic and eosinophilic leukemia. For CNL, it usually has this CSF3R mutation, so that's easier. For CEL, there's no specific one, so that's tougher for everyone to pin down. Usually, if there's increased eosinophils, there's a lot of other things to rule out before you actually get to this sort of thing. So it's a very uncommon diagnosis. So these are for your MPN approach. You're going to look at the peripheral blood, get a differential diagnosis kind of based off of this, then do a bone marrow biopsy to specify. And your NGS, so you see the features on the peripheral blood, you might do JAK2 testing, but you're also going to make sure you do NGS testing on the bone marrow biopsy to figure out what clone there is. So that's how you get through the 7 adult choices. There is a juvenile thing, that's the JMML if you look in your workbook, that I'm skipping. Focusing on the adults. So myelodysplastic neoplasms, or MDS, or myelodysplastic syndromes, that also has a Venn diagram that can be made. This one's a little bit different because all the cytopenias are kind of lumped together. So it doesn't not specifically have to be leukopenia or anemia or thrombocytopenia. There can be any of them. But then you also want to find, you won't, but the hematopathologist would find dysplasia. So the cell's looking weird, abnormal maturation. And then you would want to be able to define a clonal abnormality. And again, you need all 3 of them, because if you have 2 out of the 3, then it's something else. There are 6 to 7 main categories for MDS in the adult. There are these that are genetically defined. These are morphologically defined. So the genetically defined ones there's only 3, with MDS with biallelic P53 mutations, MDS with low blast and deletion of 5q, which is a long arm of chromosome 5, MDS with low blast and SF3B1 mutation. And then by morphology, there is an MDS with low blast, and clearly without these. One that is hypoplastic, so there's not as many cells in the marrow. Usually with the MDS, you expect the marrow to have lots of cells. So there's a variant that doesn't show that. There's MDS with fibrosis and MDS with increased blast. So basically you need to answer 6 questions and then you can go through your list. 6 questions are, is there a TP53 mutation? If so, then you do this. Is there a del5q? Is there SF3B1 mutation? Is there some other clonal abnormality, just to prove the clonality? And then you need the number of blasts to let you know whether there's increased blasts or low blasts, and then whether there's fibrosis or not. Once you answer those questions, then you just go through the list. And I have this flow chart. You have to show that there is cytopenia, of course. You want to show there's dysplasia to get started, and there's clonality. Then once you rule out all the other non-specific things, drugs, nutrient deficiencies, okay, you're dealing with an adult. There's P53 mutation, that takes precedence. And then you also want to make sure there's none of the AML defining abnormalities. And then based on the number of blasts, you go one way or the other. If there's low blasts, then you can think of del5q or SF51 or the hypocellular variant. If there's increased blasts, if there is fibrosis, then there'll be MDS with fibrosis. And if there's not fibrosis, then you have MDS with increased blasts. Again, all this is easier to do once you answer these 6 questions. So there's a sheet of paper or on the side, you answer those questions, and then follow the flowchart. Again, there's not that many choices here, there's only 6, but I think this puts some structure to it. Oh, this last one. So the myelodysplastic myeloproliferative neoplasms. It sounds complicated because it's a really long name, but in terms of diagnoses, it's kind of not as complicated because there's only 4 real choices. Chronic myelomonocytic leukemia, which is characterized by an increase in monocytes that's unexplained. If you think back to the MPN page, so the leukocytosis could be neutrophils, eosinophils, red blood cells, platelets. You skip the monocyte. And then there are these other 2 things. There are some older names because the names just recently switched. So I don't know if you've heard the name atypical CML. So it's basically like a CML that doesn't quite look like CML, or it's a CML almost like picture in the peripheral blood. You don't have as much basophilia. You see more early myeloid precursors. You might see some neutrophils that look a little bit weird, and you don't find the 922 translocation. There's other mutations that are associated with this, but it kind of presents like a CML, but it doesn't have that classic mutation. And then this other one, another long name, myelodysplastic myeloproliferative neoplasm with SF3B1 mutation and thrombocytosis. I like the old name better because it still describes it, which was refractory anemia with ring sideroblasts and thrombocytosis, which is very descriptive. So there's anemia, ring sideroblasts, which are red cell precursors that have iron dots everywhere, and thrombocytosis, which is increased platelets. So they found that most of these cases have this SF3B1 mutation, so they put that in the name instead. But they kind of skipped out the anemia part. But that's going to be your thing that's low or decreased, and thrombocytosis is the thing that's going to be increased. And then if there's something that doesn't fit with any of these categories, since you only have 3, then there is this MDS, MPN, NOS, or unclassifiable category, which means I'm not sure. It has features of overlaps, but I'm not sure which one it is. It doesn't get classified well. So again, for all of these, you're going to be looking at the CBC to get you started. And once you rule out all the reactive things, drugs, medication, or all these other sorts of things, nutrient deficiency, drugs that the physician has given them for some reason or another, then you can start to think about these. But these all require a bone marrow biopsy to actually diagnose. So there's 17 of those altogether. It's probably more straightforward to get through some of the MPNs and the MDSs. The overlap is a little bit tough. So that's the chronic myeloid neoplasms. These next 2, large cell lymphomas, large B cell lymphomas. They can look like this. Large cells you can't really see the cell membrane between them in this, but there's lots of cytoplasm. The nuclei are really big, round, irregular, round, oval. They have little divots and stuff in them, loose, and then prominent nucleoli. Now for these, there's a lot of diagnoses, but we're going to simplify it down to 5 questions. 5 questions and a caveat. Now the good thing is that most of these names are pretty descriptive, and so it'll tell what they have as long as you ask the right question. Kind of like if you play musical instruments and you think of chords, the name of the chord has what you're supposed to play in it. It's like a major 7th, play the 7th note of the scale. If it's a 6th chord, play the 6th note of the chord, of the scale. So a lot of these are the same way. You just have to ask the right question, and the questions are architecture, location, if there's a specific infectious virus. The ones we usually care about are EBV, but we also care about HHV8, which is a human herpes virus 8, KSH Kaposi sarcoma virus, herpes virus. We care about which rearrangements. We can tell rearrangements in MYC and BCL2 and 11q. We can tell that by fish studies. And then how hard it is to prove that it's a B cell. Some of them play along nicely and are positive for all of the B cell markers, and some of them try to be tricky and want to lose some of the B cell markers. And so they're positive with only like 2 out of the 5 possibilities instead of 5 out of 5. We also want to think about history because some of these can come up as a transformation from a lower grade process or in response to immunodeficiency. So what are the types of architecture? In this graph here, the large cells are red, so they can either be scattered, they can be in big clusters, they can be in a fluid, or they can occur as sheets. And these, of course, the scattered and in clusters, since it's lymphomas that we're talking about, this is all within some sort of mass, either increased lymph node or mesenteric mass or something like that. But you can have scattered large B cells within a larger background of other sorts of cells. So that's architecture. Based off of that, you're going to have a particular differential diagnosis. You can also think of the location. If you have sheets of cells, the location becomes super important. Are these cells located in the brain? Are they located in the mediastinum, the chest area? Are they located in the skin or mucosa? Are they in the lung? Or are they in a vessel? These are important locations that will have you go to a different diagnosis. If they're not in one of those specific places, then you want to think about whether they are retaining all your B cell markers or is there loss of B cell markers. If they're retained B cell markers, then there's some cytogenetic studies that you can do. And we also want to wonder whether they are positive for EBV infection. If there's loss of markers, there are some of these other things that are more complicated. So put them all together, this is a flow chart. And I'm just going to describe the number of diagnoses within each part of the flow chart and not go through all of them specifically because we are actually running out of time. But basically we're converting this into this. And so it makes it a lot easier to deal with. So if you see scattered cells, you want to think about these 4 choices. There is this T histiocyte-rich large B-cell lymphoma, lymphomatoid granulomatosis, and then the 2 Hodgkin, then classic Hodgkin lymphoma, and then the Hodgkin variants, nodular lymphocyte predominant Hodgkin lymphoma. If it's nodular, then there's fewer choices to worry about. Just these 2 mostly, follicular large B-cell lymphoma, and there's an ERF4 rearranged large B-cell lymphoma, which is defined by the ERF4 rearrangement. If it's in fluid, the F here is fluid associated or fluid overload, and then the pleural effusion lymphoma. So those are, again, just describing where they are. If we're in sheets, then based on the location, that gets a name, and most of these names are named after the location. This one, CNS, retina, testis, these are immune privileged areas, so they're called large cell lymphoma of immune privileged sites, or primary large cell lymphoma of immune privileged sites, to show that they started there and it's not a metastasis from somewhere else. The ones in the mediastinum have mediastinum in the name. The one in the skin has cutaneous in the name. And for this other one, EBV mucocutaneous ulcer, again, cutaneous in the name. Intravascular, it's called intravascular large cell lymphoma. If it's not in any of these particular locations, then you get into some of the more names that you probably heard more about. Things such as Burkitt lymphoma, which only has the MYC rearrangement and nothing else. The double hit lymphoma with MYC and BCL2 rearrangements. And if those aren't there, then you can go further to see if there's 11q, where there's EBV. If all these things are negative, then you're just stuck with NOS, diffuse large B-cell lymphoma, not otherwise specified, and you can think of germinal center phenotype or non-germinal center phenotype. And if it's hard to identify the B-cell markers, then there are these 3 things you can look up. ALK expresses ALK, and nothing else expresses ALK. That one's easy to do. HHV8 positive, which hardly any of these other things are HHV8 positive, and plasmablastic lymphoma, which is usually EBV positive. But again, 5 questions: architecture, location, retained B-cell markers or lost B-cell markers, rearrangement of MYC, and these other things can help you go down the flow list. Some places will call something a aggressive B-cell lymphoma when they know that they have just like 2 large cells and they're still trying to figure out all the other things. And then they'll give a more specific diagnosis once they get all the rest of the studies done. And again, I mentioned consider the history, because some of these can show up after a low-grade thing, and some of these can show up in immunodeficiency. And so they might treat the patient a little bit differently if they find something in a kidney transplant patient. Or last one, small B-cell lymphomas. Again, we're breaking this down into the diagnostic questions that enable you to navigate to the diagnosis rather than like every little specific detail of every lymphoma here. Have it in 2 steps. The main ones that are most simple to find, I think, are small lymphocytic lymphoma or chronic lymphocytic, small lymphocytic lymphoma / chronic lymphocytic leukemia, depending on how it presents. It's called leukemia if it's in the peripheral blood, lymphoma if it's in a lymph node, but they both have the same phenotype, same protein profile. You want to think of whether you have SLL or mantle cell lymphoma, that's the MCL, that has a specific translocation, or determine whether it's marginal zone-like or follicular lymphoma-like. So you can answer this question usually by looking at CD5 expression, CD10 expression on the cells. If it's CD5 positive, you're going to be thinking SLL or MCL. If it's CD10 positive, you're going to be thinking follicular lymphoma-like. And if it's negative for both of them, then you're going to be thinking marginal zone lymphoma-like. So if it's CD5 positive, then if you can pin it down to SLL or MCL, mantle cell lymphoma, then you're done. And there's a lot of SLL, CLL, SLL, so that takes care of a lot of things. And if it's marginal zone-like, either negative for both, then you want to try to localize it we'll go to more of those on the next slide. And if it's follicular lymphoma, like say CD10 positive, then you also want to further specify it. And a lot of these are based on location or other sorts of features within the patient. So these are the choices for the follicular lymphomas and your marginal zone lymphomas. Again, I'll start with the marginal zone lymphomas. Said you want to locate it. So splenic marginal zone lymphoma. There's another splenic diffuse red pulp small B cell lymphoma. So this refers to the two parts of the spleen, the red pulp and the white pulp. If it's a white pulp thing, then you're going to be thinking splenic marginal zone. If it's in the red pulp, then diffuse red pulp. Extranodal marginal zone lymphoma of mucosa-associated lymphoid tissue. The location is in the name, mucosa-associated lymphoid tissue. So lymphoid tissue by your mucosa, so like in the lung or in the colon or in the something where you have some sort of access to the outside world. Primary cutaneous marginal zone lymphoma, so it's in the skin, starts in the skin. Nodal, so that's in the lymph node, and then pediatric nodal in the lymph node in a kid. So again, you have the general phenotype, location, and you're going to get really close to diagnosis. Same thing is true for follicular lymphomas. The location is going to help you get there a lot of times. There's a duodenal type follicular lymphoma if it's in the duodenum. Primary cutaneous, the name here is follicle center lymphoma. It's a follicular type of lymphoma. If it's in the skin, pediatric type, it's in a kid. And then there's a testicular follicular lymphoma if it's in the testis. I have it in brackets here because in one classification system it's its own thing, and in another classification system it's kind of included with something else, but it's still a particular type. There's this predominantly diffuse growth pattern, which is again described as you see on the microscope. An unusual cytologic features if it has the phenotype but if it looks a little bit weird. And if it's none of those, then you can think of these other ones, lymphoplasmacytic lymphoma, which again, the name is very descriptive. They are small B cells that look like lymphocytes and also some that look like plasma cells. And so you see a spectrum of lymphocyte, plasmacytic lymphocyte, plasma cells. And then there's a splenic B cell lymphoma, leukemia with promonucleoli. That is a weird category that has some overlap features with some other diagnoses. So it's not one thing, it's kind of like a heterogeneous category. But if it doesn't fit into some of these other ones and has promonucleoli, then you can bring that into your differential diagnosis. However, big picture, think of whether it's positive for CD5 and you're going down CLL, SLL versus mantle cell lymphoma, differential diagnosis, whether it's positive for CD10 and you're thinking follicular lymphoma, then you want to localize it. Or if it's marginal zone-like, it's negative for both of them, then you also want to localize them. And that can get you through most of these. So we've gone through a lot. Covered acute myeloid leukemias, 38 diagnoses, how to handle them. B-acute lymphoblastic leukemias, 13 diagnoses, how to handle them. Chronic myeloid leukemias. We hit the highlights. The morphology is super important, but how you get to it, there's some basic principles you can use to get to it and how you would think about your differential diagnosis. Large B-cell lymphomas, there's 25 of those. And again, the 5 questions of architecture, location, retainment of B-cell markers, cytogenetics, and infection. That will get you where you need to go most of the time. Small B-cell lymphomas, 3 main branch points, whether you're going to do the CLL, SLL versus mantle cell, whether you're going down a follicular-like pathway or you're going down a marginal zone-like pathway, and a couple exceptions. But about 17 with those. So we actually covered a little bit more than 100. But these are pearls to help you get through them. They'll help you understand a pathology report if it doesn't give you as much specificity as you would like, or if it's not as much specificity as they would like. Know that more things are coming, especially if it's acute myeloid. Any of the acute things, more information is probably coming if the report came out very quickly. So we know some themes. You always want to think about how the patient is affected. From a primary care perspective, this is how things will present. Whether you are surprised by the CBC or not surprised by it. So if a patient comes complaining of fatigue and being tired all the time and there's anemia, oh yeah, of course. Or they're bleeding and there's thrombocytopenia, it's like, okay, of course. So there's some ways that the patient's affected, but lymphadenopathy or bulge or mass somewhere, you want to think about those. Those are all important to the diagnosis, being able to describe what you see under the microscope. Often those are clues to the diagnosis. Pay close attention to the location of the disease. That's going to get you to the name in a lot of the cases, or at least give you more information about it, whether it ends in leukemia, it's in the peripheral blood or marrow, or whether it's primary cutaneous follicle center lymphoma. Primary cutaneous started in the skin, follicular or follicle center, CD10 looks like the follicle. Lymphoma, it's a mess. And so it helps you deconstruct the names to make more sense out of them. The importance of cytogenetics or FISH reports and molecular reports, knowing what rearrangements of chromosomes are there, super important. Knowing what mutations of the DNA are there, super important. Being able to describe the immunophenotype. So whether there are B cell markers, whether there's all the B cell markers, whether there's only a couple B cell markers, whether you have all the myeloid, immaturity markers, or only some of them, or a mixture of markers. These are all important. So you want to make sure you collect all that information from a pathology perspective and from a clinical perspective. Understand that these are some of the pieces that they're going to need before making a diagnosis. And then also checking the history for low-grade disease. These are some of the keys. It becomes, again, infinitely easier when you have a kind of pathway to go through and you know what pieces you need to collect before making the journey instead of just trying to spot diagnose something. Go through the steps. And then the final lessons, again, set a foundation by briefly reviewing everything within a particular category, and then you can look for defining characteristics. And then you can add additional details, exceptions, variants, and all that sort of stuff to your framework over time. Feel free to follow me on Twitter. And with that, we're going to end.